So thank you very much for the very kind introduction. So it's a great honor to present to you. So just a disclaimer, I am a clinician. I work in critical care medicine. I have a background in kidney medicine. I'm going to explain how those interests are relevant to this presentation shortly. I'm not a trained expert in epidemiology or data analysis. I hope I am a semi-skilled amateur. So it is very useful to come and present before these forums because you may be able to give me some very important feedback in our research. But hopefully we're also to bring a few clinical insights to the analysis that help perhaps speed things and ask the most appropriate questions. This work's been done in conjunction with my research fellow, Dr. Giada Azipadi, who's also a intensive care and renal doctor in training, and she's prepared many of the slides that I'll show you. So the question is, why am I interested in this area as an intensive care doctor? And the problem with patients who are in intensive care is that we spend an enormous amount of resources getting them better, and they leave hospital, but they leave hospital sometimes a shadow of their former person with very significant physical sequelae of their illness. This example here, taken from a news website, was a nurse who was extremely muscular, got severe COVID-19 disease in the ICU for a long time, and lost a huge proportion of his muscle mass. Now imagine people with lower degree of muscle mass at baseline, how profoundly they can be affected by significant critical illness. So we're interested in the assessment of muscle mass, and I am also interested in the assessment of kidney function in these patients as somebody with a kidney background, as a sort of an exemplar of chronic organ dysfunction in this population. But actually then this interest spreads out to the wider population. Really, we're interested in patients who have or are at risk of acute illness, and how we can help them, what their risk is, and both before and after such illnesses. I work very closely with a colleague of mine, Professor Zudin Puthacheri, who is a muscle biologist and intensivist. And this is his seminal paper from his PhD, where he demonstrated profound loss of muscle mass and muscle quality in patients during critical illness. And this is some of the histology from his work. And you can see just in the same patient over the period of 7 days, very significant loss of muscle quality, and indeed in the infiltration of inflammatory and fibroblastic cells into the muscle. And you can also see this on ultrasound and many other modalities in the same patient, very significant loss of muscle mass during a very short period of time. And we've meta-analyzed this, and it's actually about 2% loss of muscle mass per day. So we're extremely interested in the critically ill population as a tip of the iceberg here. But sarcopenia is a very important and consequential baseline risk and outcome in a wide variety of other areas of medicine. But what about the kidney? How does the kidney come in here? Well, you may or may not know, but our primary biomarker of kidney function that we use is the serum creatinine concentration. And creatinine is freely filtered in the kidney and excreted in the urine, and so we use its plasma concentration as a proxy of the ability of the kidney to excrete it. But this neglects the fact that creatinine comes from somewhere and is actually a breakdown product of the creatine that you have in muscles, which is derived from your diet and from the liver. And so, in fact, creatinine is something that's indirectly excreted by the kidney, but is actually predominantly a biomarker of muscle mass and bioenergetics. And we neglect this factor in the majority of clinical medicine. And this may be okay if patients have relatively stable muscle health, but is certainly not the case in patients with disease states that are affecting their muscle health. And so there's two sort of opportunities here. One is that we can better assess kidney health in our patients, and B, we may be able to leverage creatinine to give us an insight into patients' musculoskeletal health. You may be aware that we use estimated GFR formulas to correspond between serum creatinine, which is roughly reciprocally related to GFR, and the true estimate of GFR. And these are based on population estimates of muscle mass in patients, and effectively they are estimates of the underlying muscle mass in the stable outpatient population. And they may therefore not be accurate in disease states, but we use these without really considering their applicability. And this is data from some years ago as well, and it just shows that patients leaving the ICU, even if they've had significant acute kidney injury, often have significantly abnormally low serum creatinines, lower than baseline, reflecting their level of muscle loss. And there's, again, two possibilities here. One is that we can understand their degree of muscle illness, and also that we can understand better their level of kidney function if we could actually make an assessment of their true muscle mass and perhaps have a better alternative to creatinine. And we do have a better alternative to creatinine, at least in some states, which is another analyte called cystatin C. This again is released and excreted in the kidney, and it's freely filtered. Happens to actually be reabsorbed in the tubules, so it's and metabolized, so it's not doesn't appear in the urine, so we can't measure its urinary clearance. We can measure its serum concentration, and it's released from all nucleated cells, so it's less affected by the sarcopenia, alterations in muscle mass. It's also not affected by some drugs that affect creatinine excretion in the tubules. However, it may be affected by some other disease states that we will go into a bit later. But you can see here that this is a study where they actually looked at the estimated GFR based on equations using creatinine and cystatin C. And on a population basis, cystatin C was better able to predict death from any cause than the eGFR based on serum creatinine, despite the fact they were calibrated to the same thing. And serum creatinine had this U-shaped distribution where patients with apparently high GFRs were having worse outcomes. And this may be because their apparent high GFR was actually due to inadequate creatinine production due to low muscle mass. But it's also true that there may be some other factors that may be making serum cystatin C more predictive of death, in addition to the effect of it revealing kidney dysfunction in the background of sarcopenia. In the ICU, I did some work in collaboration with a group in Stockholm in the past, where we looked at serum cystatin C. And we looked at the discrepancy between the GFR estimates between serum cystatin C and serum creatinine at ICU discharge when patients were back in steady states. Patients with a longer length of stay had a serum creatinine was significantly, sorry, a serum creatinine eGFR that was significantly higher than their cystatin C eGFR. And we hypothesized this indicated muscle loss in these patients. And cystatin C was a much better discriminant of our overall ongoing risk of death in these patients after ICU discharge than serum creatinine, presumably because a large number of patients had normal serum creatinine because they had impaired kidney function and loss of muscle mass, putting them at combined high risk that was not well discriminated by this analyte. We did some prospective work looking at this in the ICU population recently, where we also measured GFR using a technique called ihexyl clearance. And we were able to, and we also measured muscle mass. We were able to demonstrate again the substantial loss of muscle mass over time in the ICU in our population. And we found that that was accompanied by effectively an overestimation of kidney function by creatinine compared to cystatin C, reflecting the fact that there was presumably a loss of underlying creatinine generation with the loss of muscle mass. This is effectively the same thing. And what we found overall was that when we measured GFR, the serum cystatin C was giving a much better estimate of overall kidney function. The serum creatinine was giving a gross overestimate of kidney function, likely as a reflection of these patients' documented loss of muscle mass. So really evidence that we wanted to look more at serum creatinine and serum cystatin C in patients after ICU discharge, but in other patients who might be sarcopenic. So this just makes a point here about the derivation, the relationship with serum creatinine, generation rate, and GFR. Serum creatinine in the plasma is reciprocally rated to GFR, and the constant of proportionality effectively is the generation rate. And really the point being is that you could have somebody with a plasma creatinine of 100 and they could have normal muscle and normal kidneys, or they could have very poor muscle and poor kidneys. And this patient in the latter group is at high risk, and we can't discriminate them unless we use another analyte. It's also just important to reflect that actually patients with overt CKD are sarcopenic, but this is accommodated within the derivation of the formulas because these patients are in the community being sarcopenic. And so actually the creatinine equations probably do perform quite well at low GFRs with patients with high creatinine. It's really these patients where we're not capturing relative early to moderate CKD with severe sarcopenia that we're missing in this analysis. And that's not been well brought out in other people's analysis of the correspondence between creatinine and cystatin C. So these were opportunities to leverage creatinine as biomarker muscle mass and potentially to screen for covert CKD in patients with significant sarcopenia, in particular survivors of acute illness and those with other chronic diseases. And so there's a construction that has been used to effectively derive a proxy of muscle mass, which is called the Creatinine Muscle Index. And this was developed by a group including Andrew Levy, who's one of the foremost developers of the eGFR equations. And effectively, this turns around the relationship between effectively creatinine excretion and creatinine generation, which will be equivalent at steady state. And it can use a GFR times the plasma creatinine concentration as estimate of the generation rate. And we can substitute the eGFR cystatin C, which should be less affected by muscle mass, into this equation to generate this creatinine muscle index, a proxy of the generation rate. Importantly, this creatinine muscle index will be normalized to 1.73 meters squared because the eGFR equation is normalized to a standardized body surface area. So it's an index of muscle mass to your size, not an absolute measure of muscle mass. And that's important when we go on to try and validate this. In this original paper, they did some validation of the CMI in a population of patients who were in a long-term follow-up study of aging, and they were measured at 2 different time points. And they found that the CMI, crudely according to Tertals, correlated with measures of frailty in their population. And they also found that a lower CMI in an adjusted analysis was associated with the increasing hazard ratio for mortality over time. And but this is just a preliminary data with this metric, and we need a better understanding of how it can be used. So we're seeking to look at this in UK Biobank. We're not the only people looking at creatinine and cystatin C in UK Biobank. However, I think that I'm providing perhaps a more comprehensive analysis overall. You're extremely familiar with this population, but just to recapitulate, almost 500,000 or so participants, although a little bit less than that when you get to the people with full data. And importantly, they had assessment of their creatinine and cystatin C at baseline. And this is vastly the largest cohort of patients with cystatin C measurements. They also had a number of measurements of muscle strength and frailty and some measures of body composition. And it's also important that sometime after their initial visit, a large cohort of patients within UK Biobank came for some imaging studies, and these included MRI and another form of X-ray measurement called DEXA. And these are considered gold standard measures of muscle mass. And this provides an opportunity to assess the creatinine muscle index within the UK Biobank population for its ability to predict muscle mass. And so this was our plan. It was to validate CMI as a measure of muscle mass against gold standards, and then to investigate CMI as a discriminator of sarcopenia and frailty and a predictor of mortality in the whole population. Excuse me. And so this is the patient population that we had, only a small number didn't have baseline bloods. But of this, there's this really substantial MRI cohort, 36,823 individuals. There was some missingness, but we had over 30,000 patients here. And we also had this other slightly less good gold standard measurement using X-rays called DEXA that we were also able to investigate in addition to the whole case cohort. This is just to show you how good MRI is at measuring muscle mass. You get these cross-sectional areas, but you can effectively integrate these into order to determine the muscle mass within the thigh here, and so we can get a whole thigh measurement of muscle mass. And indeed, we can also look at the characteristics absorption of the muscle tissue, and we can actually subtract the amount of fat content within the muscle, effectively the marbling of the muscle, to actually get a measurement of the proper quality muscle capable of doing work and contraction. And so this is a very high quality measurement that's available, already pre-processed within the biobank data. But there were some issues here with our validation analysis, and this is where I get more into the areas you may be more familiar with and the areas I'm less familiar with. So we needed to normalize the MRI measurement to body surface area, because the MRI measurement was an absolute measurement and the CMI is normalized. There's also the issue that the CMI is derived from two different blood tests, and includes the EGFR formula, and there's potential there for a greater degree of imprecision, compound errors in the measurement of different analytes. And also the fact that has to be acknowledged that the bloods and imaging were measured some distance apart, and while many of the patients will have had relatively stable muscle mass during this period, some will not have done. I think that the MRI cohort is definitely pre-selected for patients who were relatively well, but certainly they were not measured concurrently. So here's just some further issues. You may think why we can't just denormalize the CMI and keep the gold standard alone. But the problem then is that we're really just comparing muscle mass measurement to the body surface area, because we're multiplying the CMI by the body surface area. And muscle mass is going to be trivially related to your body surface area. And so that would give us add in a spurious level of correlation that might have not got through the reviewers. We're also, and this is very important, trying to validate a measure of sarcopenia on a cohort of generally healthy volunteers with actually a relatively low prevalence of sarcopenia. And so this moves on to the fact then that much of the population variation in the muscle mass, and particularly the CMI, which will have more noise in it, may be due to measurement error within this cluster of relatively normal patients, rather than the actual biological variation in the proportion of muscle within this population. And actually normalization to size really reduces the variation between individuals, because we're not looking at their natural variation in height and size. We're just looking at their proportion of muscle mass. And so we really need patients who are really genuinely sarcopenic, and a few bodybuilders within this population to really look at the biological variation that we're looking for. And so this really is a problem, because it will flatten any linear correlations, and it's what we think you call an imbalanced regression problem. And imbalanced regression problems are perhaps better known in various forms of classification problems, where you're seeking to do regression analysis or other forms of machine learning to classify relatively rare events in your training data. But this is a problem with imbalanced regression in linear regression. So here's the illustration here. And what we've got here is the total free fat mass and the CMI. And you can see that the CMI variation is a bit more shoved together. The difference between men and women is less apparent. Women have less muscle mass than men. Overall, if we just analyze men and women together, there's a relatively good correlation, but it's a little tricky to analyze men and women together, because you could just say that what the CMI is just doing is distinguishing between sex. And we really wanted to analyze these two groups independently. And what can see happens here, if we do the regression in men and women separately, we get this rather flat regression line with a very high intercept that's not really biologically plausible. It's not detecting the actual true population overall when you include men and women together, and gives a relatively poor correlation coefficient as well. And so we wanted to try and deal with this. So this shows overall that the R squared is not bad for men and women combined, but when you look at them individually, it's suggesting only 13% of the variation in the MRI is related to the variation in the CMI. But as I said, this is an imbalanced regression task. And the problem here is that I have non-uniform preferences across the target variable domain. I wanted to be able to distinguish patients with clinically significant sarcopenia, which are at the lower end of the range, from this large number in the middle. And the most important ranges are poorly represented, whereas the ones I'm not interested in are very overrepresented. So I thought about how to deal with this, and one technique that I read about is the SMOTE technique, where you do minority oversampling by imputation of cases, and you can also then do undersampling at random in the overrepresented cases. But this is relatively problematic and difficult for me to implement. There are obviously the effects of random choices, so you need to do several iterations, and they're relatively arbitrary choices about what we think are the regions of interest and the regions we want to downgrade. And in each different iteration, I'm effectively creating data and throwing away data, and it doesn't make it very reproducible. So I looked at another approach, which was to do density-based weighting for imbalanced regression, and this is partially derived from this publication here, where they used the kernel density estimation of the prevalence of the data, and then derived a weighting function to effectively weight for the sparser areas of data and underweight those areas which were overrepresented. And they had a particular weighting function in this paper, which involved subtracting a multiplier of the kernel density at the area where a particular data point was. However, there was a sort of an effectively arbitrary choice about the level of alpha, the weighting of the subtraction. And then they also need to avoid negative weights. So there was also an arbitrary choice of a very small number that you decided the weighting in the most prevalent areas of the data. And this really didn't work very well for my data set, which had a huge amount of data right in the middle, despite having very large numbers. So having reasonably plenty of data at the extremes, but really a lot of down weighting I need to do. And there were some rather arbitrary choices. So I've made a slightly brave choice to devise our own methodology, which I'd like your comments on, which was to weight to the reciprocal of the kernel density, but with a small amount of limitation of the maximum weights of the extreme outliers. And effectively what this is seeking to do is to minimize the root mean squared error across the range of the data and not the distribution of the data. This is in a log scale here, so because you can see we've got a huge amount of density of data in the middle here. And what you can see here is that the weighting is reciprocal to the density, and so the weight times density, i.e. the significance of that particular part of the data in the model, remains flat throughout, apart from the extreme tails, which I de-weighted. And so this was the approach that we chose. It still allows this weight of data in the middle to tell us about the distribution, and hopefully picks up this large amount of data we have about sarcopenic patients in conjunction with the rest of the data. But this is a sort of a relatively novel choice for this form of weighting. And I'm going to need to justify this. I did a little bit of simulation. I've chosen here a sort of favorable example to myself, but we simulated biological truth and two markers, one of which is got more random noise in the other, but there's obviously then a true relationship based on the actual biological truth variable. And then we can look at the correlation of this data, and you can see the unweighted regression line has a very poor R squared, but the weighted regression line has a good R squared and was quite close to, in dotted line, the actual relationship that I've modeled here. So it demonstrating that this approach potentially can work if you have the right data set. It's important to note here that in this weighted regression, if we want to calculate confidence intervals for the R squared and also for the regression line, then we need to use a bootstrap methodology to calculate them. Other methods that might be derived from aspects of the modeling don't account for the weighting, which will obviously enlarge the confidence intervals compared to the unweighted analysis. And so this is what we did in UK Biobank. This is the data here for males. And you can see here the flattened regression line and the actual regression line with the weighting. And you can see that the R squared was 0.47, which appears very good compared to 0.14 for the unweighted analysis. And this is putting everything together. And you can see for males and females, we have two regression lines that are effectively near parallel and really quite close overall, better reflecting the population overall, i.e. the relationship between men and women. And it's a little bit easier to see here when I've got the density, the heat map here for the density here. You can see the effects look a little clearer, that we're still taking in the middle of the data, but we're kind of down weighting the side scattering and concentrating on the extremes of the data, and I think revealing the true biological relationship. And I think this is plausible because the regression lines derived independently for males and females near overlap, indicating they're detecting the same biological process within these two distinct populations with different baseline muscle mass. And also the intercept is close to 0, which is much more biologically plausible than these very high intercepts, really just detecting the fact that men and women have overall different average muscle mass. We also applied this to the DEXA, which is, as I said, a slightly less good measure, and indeed it showed very similar results here. Again, adding some additional plausibility. And hand grip strength, which is which again is slightly difficult to normalize. You normalize it to height and will be much more imprecise, but we can look at in the whole biobank population. And we can see here that there appears to again be a better relationship between CMI and hand grip strength, which is similar for men and women and has a close to 0 intercept compared to the flattened standardized regression line, unweighted regression lines. So what about the ability then of CMI, if I can accept that it has some external validity to detect sarcopenia across a biological range? Well, what we've done here is we've divided up age groups, and this is Charleston comorbidity index. The level of comorbidity is relatively low in the biobank population, although it increases with age, obviously. And what you can see here is that obviously creatinine muscle index decreases with age overall, as you'd expect. I'm afraid as we age, we become more sarcopenic. But within each age group, there was a strong, and it's statistically significant, and I've not illustrated the tests here. I think you need the John Cassidy-Turpin test here to look for the difference between ordered groups, but they're significant across all of these age groups. And you can see here that then the CMI is discriminating patients with comorbidity. And the biobank also has a number of different measures of frailty. There's a very large frailty questionnaire. Others have combined this with some other physical methods. But within each age group, we looked at measurements suggesting patients were robust, had perhaps what they determined pre-frailty, and then actually had overt frailty. And again, you can see here that the CMI was very effective at discriminating these within each age group overall. Obviously, to really test discrimination, we need to use a sort of ROC type analysis. There are some overall definitions of sarcopenia. These are actually based on things like hand grip strength and a measure called a body composition based on bioimpedance, both of which are actually relatively crude and again have got applying an arbitrary cutoff. Nevertheless, the Creatinine Muscle Index was able to discriminate sarcopenia by these definitions with an acceptable AUC. However, I would say that the gold standard here for sarcopenia is far from golden. It really is a rule of thumb that's been used in clinical studies for want of anything else, and it may be CMI is actually better at discriminating than these measures, and we need to investigate that in other things. And survival analysis is probably the most unbiased way that we can try and look at to see how this measurement is predicting patients' long-term outcomes, although of course there are very many confounders. This just shows you overall the incidence of death over time in the UK Biobank population for men and women. And so, and we've got kind of 8 years or so of follow-up in a smaller number of patients, but 6 years follow-up in a substantial number of patients. And overall, of course, relatively small number of deaths as a proportion, but still substantial numbers overall, if you think about the size of the UK Biobank population. And we took some adjustment variables and we looked at age, sex, and comorbidity index. We didn't want to kind of course, many things will correlate with sarcopenia, and you can adjust out all of your association by adjusting for many things that you don't normally measure. But of course, these are very important confounders that we include in our analysis. There are again some other sort of statistical issues, perhaps slightly simpler this time, but non-linearity of the relationship with CMI, non-proportionality if we're using a Cox model, but also the formal test for non-proportionality in terms of a slope of the time-dependent coefficient being not equal to 0 is perhaps overly sensitive in a large sample size, where you're going to find statistically significant associations even with very small amounts of change. And so what do? Well, we stratified on our confounders because obviously age and comorbidity might showed evidence of being having non-linearity, and these are just essentially adjustment variables. And then we modeled CMI to a restricted cubic spline with 5 knots to look at non-proportionality. Sorry, not to look at non-proportionality, not to look at non-linearity. This is the relationship that we saw in terms of relative hazard. Obviously, this is because it's fitted as spline, I can't just give you the absolute hazard ratio, and I need to provide you with a model. And so here we've modeled arbitrarily a man or a woman in the age group 48 to 55 with no comorbidity. But the overall shapes have been the same. We didn't model any interaction terms in this model. And so what you can see here is that there's an increasing hazard of death with lower CMI that then tends to plateau after one gets to what you might describe as a healthy level of muscle mass. But obviously this point of plateauing is different between men and women who have different levels of baseline muscle mass overall. In terms of the non-proportionality, I think I took out the slide, but it's barely statistically significant. However, if you look at the plot of the scaled Schoenfeld residuals, effectively it is reasonably flat. And so while these hazard ratios are effective in an average over the follow-up period, effectively we think they can be applied over the follow-up period, and the small violation of the proportional hazard assumption is probably not clinically significant in interpreting these models. And I don't, if others disagree with that, then I can suggest some other approaches, but we need something that has simplicity and interpretability for less statistically astute readers, and external validity. Now, there's a final warning here. So I've given you a lot of information to suggest that CMI is potentially a good surrogate of muscle mass for the detection of sarcopenia and is associated with adverse long-term outcomes. But that is assuming that the GFR cystatin C is an unbiased assessment of kidney function, and I'm afraid many investigators think that is possibly not true. But it's certainly not true that the GFR creatinine is an unbiased assessment of kidney function. And a number of investigators looked at this. This is one of the better early studies because it was able to, with measured GFR overall, to look at the variation in cystatin and creatinine GFR in a relatively large cohort, and how these related to a number of variables. And effectively, conditions where you have chronic inflammation and certain disease states like diabetes may be associated with relatively higher cystatin C production. But of course, these conditions are also associated with sarcopenia in addition, but it is true that cystatin C is a soft biomarker of inflammation. And some investigators have looked at cystatin C within UK Biobank effectively purely as a marker of inflammation and inflammatory risk. And this is a rather complex paper in Cell Genomics, which looked at potentially trying to investigate genomic terms of cystatin C production and their relationships and outcomes. And they did some complicated modeling, which I won't go through here because I don't entirely understand all of this. But the problem I have with this particular analysis is effectively they don't have a measurement of cystatin C production. So they've derived one from a process that really paid no attention to variation in creatinine production, which we can measure in cohorts where we have assessments of their muscle mass. And so effectively their measure of cystatin C production was really a measure of relative production compared to creatinine. And they also found that the relationship between their cystatin C production and an attempt to validate this really had a very poor correlation. And they used this rather strange regression model, which effectively assumed a 0-0 intercept, and so had a spuriously high R squared in order to derive this rather strange validation concept. And I really don't buy that at all. But it is nevertheless true that cystatin C production is a concern. And so these are my conclusions. CMI, I think, is a valid measure of muscle mass that correlates across a clinically significant range of muscle mass. And we should have some confidence in investigating further in that role. It is associated with frailty phenotypes, age, and comorbidity. However, it may also measure relatively increased cystatin production. That's potentially related to inflammation or use of glucocorticoids, but these are in themselves associated with sarcopenia and risk of death. And so this doesn't invalidate CMI. In fact, it probably gives it greater validity, just means that it's potentially more complex to interpret it. It's certainly true that alterations in cystatin production are difficult to measure, while measured muscle mass is an accepted surrogate of creatinine production. And so in this analysis, I think we've confidently established that a lot of the variation in CMI is related to variation in muscle mass, and therefore it's detecting important groups of patients where creatinine may be a biased assessment of kidney function and patients who may have sarcopenia. So forms of diagnostic schema where you're not relying on the CMI as a diagnostic test, but more as a screening intervention. So you measure creatinine and cystatin C. If they have a low CMI for their sex, well, they're potentially at high risk for sarcopenia and chronic inflammation. And if they have a low EGFR and cystatin C, they've got potentially inaccurate CKD staging. And so we can do other assessments to see if they have clinical sarcopenia and or evidence of chronic inflammation. And we could also measure their GFR in a group of patients we screen to that to accurately assess CKD and its staging, and so properly implement evidence-based CKD and cardiovascular prevention in its population and adequately monitor our patients over time. And so that's where I really see these things not as fighting a war, but as being complementary tests that potentially provide great screening tools, not for populations and also in particular for patient groups such as post-ICU, prolonged hospitalization, patients with cancer or have had chemotherapy, and other specific disease groups like COPD and diabetes. And so that's what I'll finish. Thank you very much.